At the end of this lecture, you should be able to know pathophysiology, etiologies, symptoms and signs, investigations to diagnose, treatment, and complications of neonatal jaundice. For the introduction, neonatal jaundice is defined as jaundice occurring in the first 4 weeks of life. It manifests as yellow discoloration of the skin, sclera and mucous membrane. It results from an increased concentration of bilirubin in the blood. In neonates, jaundice is clinically apparent when serum bilirubin is 85 micromole per liter or more. It is a common condition which occurs in up to 60% of healthy term infants. Initially the jaundice appears on the face and later progresses in cephalocaudal direction, meaning the most severe form of neonatal jaundice will involve the hands and feet of the baby. For the next 2 slides, I will explain to you about the bilirubin metabolism. First we are going to review the bilirubin metabolism. During breakdown or hemolysis of red blood cell, hemoglobin in the red blood cell is broken down to heme, which is later converted to bilirubin. This initial bilirubin is unconjugated and fat-soluble. It travels in plasma bound to albumin, and enters liver cells where it is conjugated by enzyme glucuronyltransferase. The conjugated bilirubin is excreted via the bile duct into the intestine, where it is metabolized by intestinal flora into urobilinogen, which is then converted to stercobilin. The stercobilin is excreted in stool, giving them the yellow color. A small amount urobilinogen is absorbed into the enterohepatic circulation. It is either re-excreted in the bile or excreted in the urine. Neonatal jaundice is classified according to the period that the jaundice occurs. The first is early neonatal jaundice. This can be divided further into jaundice within first day of life, which is always pathological, and jaundice which occurs between day 2 and day 14 of life. The second is prolonged neonatal jaundice, which occurs after day 14 of life. Hyperbilirubinaemia can also be divided into unconjugated and unconjugated. The unconjugated hyperbilirubinemia is due to increased breakdown of red blood cells or reduced conjugation of bilirubin in the liver. The conjugated hyperbilirubinemia is due to reduced excretion of the conjugated bilirubin. As mentioned earlier, jaundice which occurs at less than 24 hours of life is always pathological. The causes include blood group incompatibility, for example Rhesus or ABO incompatibilities. Other causes include enzyme deficiency in red blood cells, for example glucose phosphate dehydrogenase deficiency. Congenital infection by toxoplasma, rubella, cytomegalovirus, herpes and syphilis or known as torch. Sepsis, and high hemoglobin mass, for example due to polycythemia or cephalhematoma. This occurs when the mother is rhesus negative but the baby is rhesus positive. The mother becomes sensitized by fetal D antigen resulting in production of IgG which crosses the placenta, leading to lysis of fetal red blood cells. The condition typically occurs in the second and subsequent pregnancies. Baby O incompatibility occurs when the mother is blood group O, and the baby is blood group A, B or AB. At the end of this lecture, you should be able to know pathophysiology, etiologies, symptoms and signs, investigations to diagnose, treatment, and complications of neonatal jaundice. Physiological jaundice occurs after 24 hours, up to 2 weeks of life. The jaundice typically peaks between day 2 and day 5 of life. The increased in bilirubin production is due to presence of more but shorter lifespan of red blood cells in neonates. In addition, there is reduced conjugation of bilirubin due to immature liver enzymes. These lead to unconjugated hyperbilirubinemia. As mentioned earlier, jaundice which occurs at less than 24 hours of life is always pathological. The causes include blood group incompatibility, for example Rhesus or ABO incompatibilities. Other causes include enzyme deficiency in red blood cells, for example glucose phosphate dehydrogenase deficiency. Congenital infection by toxoplasma. Studies have shown that infants who are breastfed develop jaundice more commonly compared to those who are fed with formula milk. After heading, the jaundice usually starts slightly later, on day 4 of life. The exact cause is unknown, but it is postulated that this is due to presence of glucuronidase in the breast milk, which inhibits the conjugation of bilirubin. This leads to unconjugated hyperbilirubinemia. The breast milk jaundice can in fact last up to 12 weeks of life, and is the commonest cause of prolonged neonatal jaundice, which will be discussed later. Causes of prolonged neonatal jaundice can be divided into unconjugated and conjugated hyperbilirubinemia. The unconjugated causes include breast milk jaundice, blood group incompatibility, G6PD deficiency, congenital hypothyroidism, and urinary tract infection. The conjugated causes include biliary atresia, clerical cysts, intrauterine infections such as torch, hepatitis B and C, metabolic errors such as galactosemia, prolonged usage of total parenteral nutrition, as well as urinary tract infection. Please note that urinary tract infection can cause both conjugated and unconjugated hyperbilirubinemia. This is because infection by bacteria such as E. coli causes hemolysis of red blood cell, leading to unconjugated hyperbilirubinemia. On the other hand, conjugated hyperbilirubinemia may occur in the baby with urinary tract infection due to cholestasis, secondary microcirculatory disorders in the liver, or mediators released by the bacteria. Last but not least, breast milk jaundice is a diagnosis with exclusion. This means that the diagnosis of breast milk jaundice can only be made if all other causes have been excluded. Each case of neonatal jaundice must be methodically approached. This encompasses a thorough history, detailed physical examination, performing relevant investigations, and instituting appropriate treatment. Taking the proper history is important as it helps us to find the likely cause of jaundice in the baby. Firstly, we need to find out when the jaundice starts. As explained earlier, the differential diagnoses may differ according to the onset of the jaundice. Next, we need to take detailed feeding history, whether the baby has been breast or formula fed, and whether the baby has been feeding well or not. The baby who has been breastfed may have breast milk jaundice. On the other hand, the baby who has received inadequate breastfeeding may develop breastfeeding jaundice. The color of stool and urine is important, as a baby with obstructive jaundice may have pale stool and dark-colored urine. The frequency of bowel motion should also be asked, as a baby with congenital hypothyroidism may have constipation. Apart from that, the frequency of changing diaper for wet nappies gives us an idea about amount of urine being produced. This is essential, as a baby who is dehydrated will pass less amount of urine. We also need to ask about symptoms of kernicterus, such as sleepiness and seizure. Don't forget to find out the relevant factors that may increase the risk in the baby of developing jaundice. These include maternal blood group, G6PD status, thyroid screening result, and use of herbal or traditional medicine. Lastly, family history of neonatal jaundice and liver disease should be inquired. Physical examination must include assessment of the following: current and birth weight, taking note the percentage of weight loss since birth; hydrational status; vital signs, i.e. temperature, respiratory rate, heart rate and blood pressure; extent of jaundice, which progresses in cephalocaudal manner as the jaundice becomes more severe; signs of kernicterus such as high-pitched cry, hypertonia or opisthotonus; and presence of other risk factors which may have contributed to the development of jaundice, such as hematoma, pallor, or signs of infection. The investigations for neonatal jaundice differs slightly depending on the onset of jaundice. For neonatal jaundice, which occurs at less than 24 hours of life, since it is always pathological, We need to find the cause of the jaundice by sending several investigations. These include total serum bilirubin, which gives indicator of severity of jaundice, and direct serum bilirubin, which differentiate between conjugated and unconjugated hyperbilirubinemia. Full blood count, red count, blood group, Coombs test, and enzyme assay for glucose 6-phosphate dehydrogenase should be sent to rule out hemolytic causes. We also should perform septic workup or torch screen if clinically indicated. Most neonatal jaundice occurring between day 2 to day 14 of life are due to physiological jaundice. So the most important initial investigation for babies who develop jaundice during this period is total and direct serum bilirubin. If it is unconjugated hyperbilirubinemia and the level of total serum bilirubin is not high enough to require any intervention, it is most likely due to physiological jaundice and no other investigation is indicated. However, if it is conjugated hyperbilirubinemia or the total serum bilirubin is high enough to require interventions such as phototherapy, etc., investigations to find the cause of jaundice should be done as in A1 jaundice. Apart from that, renal profile should be sent if there is clinical suspicion of breastfeeding jaundice. Physiological jaundice occurs after 24 hours, up to 2 weeks of life. The jaundice typically peaks between day 2 and day 5 of life. The increase in bilirubin production is due to presence of more but shorter lifespan of red blood cells in neonates. In addition, there is reduced conjugation of bilirubin due to immature liver enzymes. These lead to unconjugated hyperbilirubinemia. The treatment of neonatal jaundice depends on the type and severity of jaundice. The majority of early jaundice is mild and therefore may not require active treatment. It can self-resolve with adequate hydration and feeding. If treatment is required, the type of treatment is usually decided based on a set protocol according to the bilirubin level. The choice includes phototherapy and exchange transfusion. Jaundice due to certain causes such as a Rhesus Incompatibility, breast milk or breastfeeding jaundice requires special considerations and treatment, as will be explained later. Treatment of prolonged neonatal jaundice is directed against the cause of the jaundice itself. Phototherapy/exchange transfusion not required as blood-brain barrier has matured and the baby is no longer at risk of kernicterus. The principle behind phototherapy treatment is oxidation of toxic bilirubin to non-toxic bilirubin, which is water-soluble. This allows the bilirubin to be excreted in urine. During the treatment, we need to cover the eyes and expose the whole body. Ensure continuous exposure except for feeding time. The duration of treatment depends on the time needed for the serum bilirubin to come down to a level that is safe for the baby. This follows the threshold set in the protocol. Complications of phototherapy include rashes, hyperthermia and dehydration. Exchange transfusion is an invasive treatment procedure reserved for severe hyperbilirubinemia in early neonatal jaundice. The principle of this treatment is direct removal of bilirubin from the circulation. The procedure involves insertion of an umbilical catheter, repeatedly removing small amount of baby's blood via this catheter and replacing it with same amount of cross-matched packed red blood cells. Follow-up with hearing and neurodevelopmental assessment is needed.
In Rhesus Incompatibility, NTD is given to the rhesus-negative mother who have been potentially sensitized.
Hyperbilirubinemia can also be divided into unconjugated and unconjugated. The unconjugated hyperbilirubinemia is due to increased breakdown of red.
Similar to breast milk jaundice, in the case of breastfeeding jaundice, treatment such as phototherapy is administered as indicated, and breastfeeding should continue as usual. However, we also need to correct the patient's dehydration either by giving intravenous fluid or top-up formula. The most important complication of unconjugated hyperbilirubinemia in early neonatal jaundice is bilirubin encephalopathy, or also known as Kern icterus. This results from unconjugated bilirubin crossing the blood-brain barrier in the first 2 weeks of life and being deposited in the basal ganglia. It can be divided into acute and chronic. Acute bilirubin encephalopathy can be divided into early, intermediate, and advanced stage. Signs of early acute bilirubin encephalopathy include sleepiness, hypotonia, and poor feeding. At this stage, intervention to reduce the bilirubin level can minimize the long-term neurological sequelae. In intermediate stage, the baby is irritable and hypertonic. The latter manifests as opisthotonus, i.e. arching of the trunk, and retrocollis, i.e. arching of neck. Advanced acute bilirubin encephalopathy is characterized by apnea, seizures, semi-comatose or comatose state, and may even result in death. This picture shows a baby who is in opisthotonus posture, which is a sign of acute bilirubin encephalopathy.
The treatment of neonatal jaundice depends on the type and severity of jaundice. The majority of early jaundice is mild and therefore may not require active treatment. It can self-resolve with adequate hydration and feeding. If treatment is required, the type of treatment.
Biliary atresia refers to a condition where there is absence of extrahepatic bile duct. The patients typically present with prolonged jaundice, accompanied by pale stool as there is no stercobilin in the stool, and dark urine as the water-soluble conjugated bilirubin is excreted in the urine. Advanced cases may present with hepatic impairment and portal hypertension. Investigations show raised total serum bilirubin level, which is conjugated hyperbilirubinemia evidenced by direct bilirubin more than 15% of total bilirubin. Liver function tests show high alkaline phosphatase and gamma-glutamyl transferase. Ultrasound scan is useful as initial imaging as it shows absent, amyl, or irregular gallbladder. HITA scan is also helpful as it shows normal uptake with reduced excretion. Ultimately, the diagnosis can be confirmed by either liver biopsy or cholangiogram. The treatment is operation known as Hepatoporto-enterostomy or Kasai procedure. This slide shows normal and abnormal stool color in infant.
The conjugated bilirubin is excreted via the bile duct into the intestine, where it is metabolized by intestinal flora into urobilinogen, which is then converted to stercobilin. The stercobilin is excreted in stool, giving them the yellow color. A small amount urobilinogen is absorbed into the enterohepatic circulation. It is either re-excreted in the bile or excreted in the urine.
The diagnosis of biliary atresia can be confirmed using liver biopsy in approximately 90% of cases. It shows proliferation of bile duct and bile staining of hepatocyte. In percutaneous or surgical cholangiogram, contrast material is injected into the gallbladder. In a normal patient, the contrast material will fill up the biliary tree and drain into the gastrointestinal tract, as shown in picture on the right. Biliary atresia is confirmed when no contrast drains into the gastrointestinal tract. The picture on the left shows a large cystic structure at porta hepatis and dilated intrahepatic duct but no contrast in duodenum. The operation for biliary atresia is known as Kasai procedure or Hepatoporto-enterostomy, in which a Roux-en-Y anastomosis is done between porta hepatis and jejunum as shown in the picture. It gives best long-term outcome if performed before day 60 of life. A few take-home points to remember. Jaundice is common. It occurs in up to 60% of term babies and almost all preterm babies in the first week of life. If jaundice appears in less than 24 hours of life, this should be thoroughly investigated as it is always pathological. Proper treatment must be promptly instituted. Unconjugated hyperbilirubinemia is associated with encephalopathy, which can result in long-term adverse sequelae. Persistent jaundice beyond 14 days should be investigated thoroughly. Identification of its cause and early treatment dramatically improves survival. An increasing level of conjugated bilirubin suggests hepatic involvement.